Every year, hundreds of thousands of Americans agree to surgery with one thought in their head: my doctor said I need this, and a number that the medical system will never openly admit did not need it at all. Some came out with complications. Some came out with consequences that followed them for years: chronic pain, scar tissue, adhesions, disrupted circulation in tissues that were perfectly healthy before anyone touched them. This is not about surgical errors or bad doctors. This is a systemic pattern. Operations are being recommended not always because they are medically necessary, but because that is how the system moves, because it is faster than conservative treatment, because someone profits from it, and because most patients do not know what questions to ask. I am Dr. Robert Anderson. I have spent years working with patients navigating exactly these decisions. And today I am going to walk you through 5 procedures that are performed far more often than the clinical evidence justifies. I want you to understand what actually happens inside the body during each one, because that information changes how you make decisions. And stay with me until procedure 3. That one surprises almost everyone. Most people have no idea it even qualifies as a surgical procedure, but it does. And the long-term consequences are real. Procedure 1. Diagnostic laparoscopy. 2 long words. Here is what they actually mean. A surgeon makes small punctures in the abdomen, inserts a tiny camera, and looks around inside to figure out what is wrong. The word diagnostic means the goal is not to treat anything, it is purely to establish a diagnosis. The person is being surgically opened in order to find information. Here is what the procedure actually involves. To give the camera room to see anything, the abdominal cavity must be inflated with carbon dioxide gas. The abdomen expands under internal pressure. The diaphragm gets pushed upward. Breathing becomes shallow. If the surgeon needs to examine the pelvic organs, the patient is tilted with legs raised and head lower than the torso. Your abdominal cavity has never in your entire life been inflated with gas from the inside. Your ligaments have never been stretched at that pressure. Your pelvic floor has never been compressed from above in that way. These are forces the tissues were never designed to handle. When the gas is released, the abdomen returns to its normal size. But stretched tissue does not simply snap back. For weeks and sometimes months afterward, patients describe a sense of heaviness, a feeling that something is off. None of this shows up in the medical record as a complication because technically there were none. And then there are the puncture sites. Every disruption of tissue heals through scar formation. Every single time without exception. Underneath the small skin scar lies scar tissue in the muscle, in the fascia, and potentially in the peritoneum, which is the membrane lining the inside of the abdominal cavity. Scar tissue can form adhesions. These are fibrous bands between organs that should glide freely. Adhesions after laparoscopy are not rare. They are an expected outcome. And here is what makes this most frustrating. After diagnostic laparoscopy, surgeons frequently find nothing, or they find what was already visible on ultrasound. The person went through general anesthesia, had their abdomen punctured and inflated, and woke up to hear everything looks fine. My position is straightforward. Diagnostic laparoscopy is only justified when every non-invasive method, including high-resolution ultrasound, MRI, and CT scanning, has been fully used and provided no answer. Modern imaging is remarkable. Use it fully before puncturing anything. Procedure 2. Surgical repair of an umbilical hernia. An umbilical hernia is when tissue pushes through a weak point in the abdominal wall near the navel. In newborns, this is extremely common. Roughly 1 in 5 infants has one, and in the overwhelming majority of those children, the hernia closes completely on its own by age 5 to 7 as the connective tissue matures and the muscles strengthen. Surgeons know this, and yet operations are frequently offered for children as young as 2 or 3 years old. Every operation means anesthesia. It means stress on a developing system. It means a permanent scar. For a hernia that statistically will close on its own, there are genuine situations where surgery is warranted. A very large hernia opening through which a significant portion of intestine can pass is one of them. The other is incarceration, where intestine becomes trapped inside the hernia and its blood supply is cut off. That is a genuine emergency. But those cases are the minority. If you or your child has been recommended for umbilical hernia surgery, ask the surgeon 3 direct questions. What is the actual measured risk of incarceration in this specific case? What is the exact size of the hernia opening? And is watchful waiting a legitimate option here? If the answers are vague, get a second opinion, then a third. There is also something you can do independently. The transverse abdominis is the deepest layer of abdominal muscle. It wraps around the torso like a natural internal corset. When it is weak, pressure inside the abdomen concentrates at the weakest points, including hernia openings. Strengthening it reduces that pressure. The exercise is simple. Stand or lie on your back. Slowly draw your abdomen inward, pulling the navel toward the spine as far as possible. Hold and then try to deepen the contraction further. Hold until you feel a deep burn, then release slowly. Done daily, this exercise produces measurable changes in abdominal wall support within weeks. Procedure 3. Intramuscular injection. This is the one that surprises people. Yes, a routine injection. By strict medical definition, any intervention that violates the integrity of skin and underlying tissue is a surgical procedure. An intramuscular injection meets that definition completely. Here is what happens to tissue with every injection. The needle cuts through skin, subcutaneous fat, and muscle. That is mechanical damage. The medication is then injected under pressure, which forcibly separates muscle fibers and creates a small cavity in the tissue. When the needle is withdrawn, the body repairs the damage the only way it knows how. With scar tissue, 1 injection, 1 small scar. 10 injections, 10 scars. A course of 20 intramuscular injections, and the muscle begins losing the elasticity that living tissue depends on. Oil-based solutions are particularly problematic. Vitamin D, vitamin E, and certain hormonal preparations are often oil-based. A water-based solution absorbs relatively quickly. An oil-based solution dissolves slowly over extended time. That means a foreign substance sits inside the muscle, sustaining an inflammatory response, and sustained inflammation becomes denser, coarser scar tissue. The more serious complications include infiltrates, which are firm, persistent lumps that do not resorb on their own, and abscesses, which require surgical drainage. And there is one risk that is almost never discussed with patients. The sciatic nerve passes through the gluteal region. It is the largest nerve in the body, governing both movement and sensation throughout the entire leg. Needle contact with it causes sharp pain, numbness, and in severe cases, permanent neurological damage. The practical takeaway is straightforward. If a medication exists in tablet or capsule form, take it that way. Modern oral bioavailability for vitamins, antibiotics, and most common medications is comparable to injectable forms. There is no clinical reason to accumulate scar tissue in muscle for an effect you can achieve without it. Injections belong only where there is genuinely no alternative. Procedure 4. Surgical facelift. The appeal is understandable. Tighter skin, a restored jawline, a younger appearance. Here is what actually happens to the tissue. Every incision in the facial region disrupts blood circulation along its entire perimeter. Scar tissue does not conduct blood as efficiently as healthy tissue. The skin fed through vessels passing through a scarred zone receives progressively less oxygen and fewer nutrients over time. The result is that skin in those areas ages faster. An operation designed to reverse aging physiologically accelerates it. The facial muscles are anatomically unique. Unlike every other muscle in the body, they attach directly to skin rather than bone. This is what allows us to express emotion. They are also connected through fascial chains to the jaw muscles, neck muscles, and the trapezius extending down to the shoulder blades. When a surgeon repositions and fixes these muscles, the tension throughout that entire connected chain changes. Head positioning shifts, neck muscle tone changes, posture is affected. These effects are real, and they consistently move the system toward disruption rather than improvement. And then there is asymmetry. No human face is perfectly symmetric, and the muscles on each side are in genuinely different states of length and contraction. A surgeon performing the procedure with technical precision, doing everything geometrically, even may still produce an unnatural result, because the baseline tissue asymmetry was not accounted for. What actually works instead? Circulation. Oxygenated blood is the most effective thing that reaches your facial tissue. What blocks it is muscular tension in the neck, poor posture, inactivity, and chronic stress. Address those, and the tissue reflects it. Facial exercises done consistently produce measurable changes in tissue lift through lymphatic drainage and improve nutrition to the skin. These approaches are not equivalent to surgery in speed, but they work with the body rather than cutting through it. Procedure 5. Cesarean section without medical indication. When the indications are real, this is a genuinely brilliant operation. Placenta previa, where the placenta blocks the birth canal. Persistent breech position creating real risk. Acute fetal hypoxia, where the baby is not receiving sufficient oxygen and minutes matter. In those situations, cesarean section is life-saving. I am not talking about those cases. I am talking about cesarean section requested or recommended without specific clinical indication. As a default, as a preference, as a precaution, without documented cause. Here is what the mother experiences beyond the immediate surgery: a permanent scar on the uterus. In any subsequent pregnancy, that scar carries the risk of placenta accreta, where the placenta grows directly into the scar tissue, and the risk of uterine rupture during labor, which is a life-threatening emergency. Postoperative pain makes caring for a newborn genuinely difficult for weeks. Breastfeeding is harder to establish because the hormonal cascade that initiates milk production is normally triggered by the physiological process of labor itself. And here is what most people have never been told about the baby. During passage through the birth canal, a process called bacterial colonization occurs. The newborn receives the mother's own microflora, bacteria that naturally inhabit the birth canal and become the foundation of the infant's intestinal microbiome and first immune defense. Babies born by cesarean without this primary colonization show statistically higher rates of allergic disease, atopic dermatitis, bronchial asthma, and gastrointestinal difficulties in early childhood. The birth canal also physically compresses the baby's lungs in a way that helps expel the fluid that has filled them throughout pregnancy. This is the physiological preparation for the first breath. Without it, infants born by cesarean require additional respiratory support more frequently. If cesarean section is being proposed to you, ask directly, what are the specific clinical indications in my case? If the answer is unclear, find another specialist. Here is what I want you to take from all of this. Never make a decision about elective surgery in a single appointment. Any operation that is not an emergency deserves time, a second opinion, and a third. Ask your surgeon one specific question. What happens if I decline this procedure? What changes in 3 months, in 6 months, in a year? If the answer is evasive, that tells you something important. In parallel, always look for what conservative medicine can do first. Exercise, nutritional correction, physical therapy, lifestyle modification. Many conditions that are classified as surgical stop being surgical under a well-executed conservative approach. This is not optimism. This is what evidence-based medicine actually shows. The best operation is the one that turned out to be unnecessary. In the next video, I am going to show you the specific questions that change the dynamic in any medical consultation and how to advocate for your own health in a system that is not built to slow down for you. Subscribe so you do not miss it.